Good morning to all. Good. It's a great opportunity for me to be present in front of all the senior delegates. And without any further ado, we will start the topic today, which is diagnostic and staging workup of a case of suspected patient of lung cancer. So, as Dr. Animesh already mentioned regarding the Globocon data, something from the Indian scenario. In India, lung cancer accounts for approximately 5.9% of all cancers and 8.1% of all cancer-related deaths. The prevalence of smoking in the patients with lung cancer is approximately 80%, which is one of the most strong risk factor which has been attributed epidemiologically towards the development of lung cancer. The lung cancer epidemiology in India has evolved from being the histological type, which is mostly associated with smoking, that is the small cell and the squamous variant, towards adenocarcinoma becoming an equivalent. And now ultimately it has surpassed that of the squamous and small cell variants as the dominant histological type. The transition in the histological profile has occurred largely in past decade, and this aspect lagged behind the transition with witnessed in developed countries. One of the postulations for the time lag has been linked to the fact that the predominant population of Indian smokers is the BD, which is used, that is the handmade tobacco smoking. It's a cottage industry based product which is not very regularized. There are lack of filters, as well as also a significant exposure to biomass fuel, which is predominantly seen in the cases of the females of the rural area, which still is predominant prior to the last few years when the government brought a different protocol of supplying subsidized rate gases to the people of the society. Prior to that, a significant proportion of our population was still using biomass fuel as one of the significant use, which has not only been a concern for the point of lung cancer, but also when we have done population-based studies in the context of COPD, we have seen that the exposure to biomass fuel is one of the significant factors for the development of non-smoker COPD, which contributes to approximately two-thirds of our total burden of COPD population across the country. Secondarily, the improvements in the molecular understanding of the molecular biology and diagnostics have helped us to pick up previously non-small cell, which were undifferentiated, where eventually when immunohistochemistry methods have improved, it helps us to understand that there is more and more incidence picking up of adenocarcinoma. So these are the population-based studies which have been done across the country by various researchers. And if we go across the years, we gradually see that the percentage of adenocarcinoma in the later phases of the studies which have been done in the population base, there has been a shift towards increased number of adenocarcinoma patients. Now coming straight away to the diagnostic and staging part in a case of suspected lung cancer. So this is usually an algorithm which happens. So how the patient flows when they present to a tertiary care center with a suspected lung carcinoma. A patient who is referred to a tertiary care with a suspected diagnosis of lung cancer, they undergo an initial clinical assessment to confirm, and thereafter investigations like pathological review and additional diagnostic procedures to obtain histological pathology, histopathology. The diagnosis is confirmed, both histopathology as well as that of the clinical stage, and additional molecular testings are advised so that we can have understanding whether we have the options for immunotherapy or targeted mutations, which are the newer armamentarium in our arsenal towards treating lung cancers. A treatment plan thereafter is reassessed, and based on molecular testing and staging workup, the targeted therapy, if the options are available, are given to the patients. And if we find that the disease is in the early phase of the staging, then the options for surgical excisions are also explored. And once the definitive therapy in the form of chemotherapy or surgery is done, thereafter we see the response to treatment with serial follow-ups. So to understand if we have to diagnose this, we have to be sanguine regarding what are the presenting symptoms, and because that is the first part where we are coming with. So the common presenting symptoms of bronchogenic carcinoma patients is cough with approximately 45 to 75 patients, weight loss, dyspnea, hemoptysis, chest pain, and hoarseness. For the expanded clinical evaluation, there could be symptoms which are constitutional, like significant weight loss, approximately more than 10 pounds, musculoskeletal, that is focal or skeletal pain, neurological, like headaches, syncopes, seizures, extremity weakness, recent change in mental status. Signs which are found usually on clinical examinations would be lymphadenopathy, hoarseness of voice, superior vena cava syndrome, bone tenderness, hepatomegaly, focal neurological signs and papilledema, and soft tissue. And routine lab features which could indicate are elevated alkaline phosphatase, GGT, AST, and calcium, and decreased hematocrit. So from the symptomatology point, it could be that the local tumor growth could be the presenting symptoms, or the paraneoplastics could be the presenting symptoms. So amongst the local tumor with which the patients can present is the obstruction of proximal airway, which leads to inability of clearing of the of secretions and pathogens, leading to post-obstructive pneumonia, where the clinical symptoms will be cough, fever, and dyspnea. It could be the tumor has spread to the pleural surfaces, where it could present with chest discomfort or pleural effusion. There could be airway invasion, in which scenario hemopsis will be a primary complaint. And obstruction of a compression of a local site, like will lead to dyspnea. Compression of the recurrent laryngeal nerve would present with the hoarseness of voice. That of brachial plexus will present with arm, shoulder, and neck point. And superior vena cava syndrome will present with facial or arm edema. And amongst the paraneoplastic syndromes, which are common ones, are the clubbing, hypercalcemia, hyponatremia in the form of SIADH, Cushing syndrome, muscular weakness, hyperglycemia, severe hypokalemia, and Lambert-Eaton syndrome, presenting as muscular weaknesses. So the diagnostic procedures will be primarily divided into two parts, that is the initial assessment and tumor sampling. The initial assessment will utilize the clinical assessment of symptoms, advanced imaging, and thereafter proceed towards tumor sampling, where we can do it in the form of flexible bronchoscopy with adjunct of endobronchial ultrasound TBNA, that is the EBS TBNA. In cases where the lung lesions, if we are finding abutting the chest wall, we can use the non-invasive methods like USG or CT guided chest biopsies. Lesions specifically in the middle third of the chest can be assessed either with the modalities depending on patient-specific factors and expertise available. Bronchoscopic techniques using radial EBUS with the help of navigation technologies, electromagnetic navigation and ultrasound bronchoscopy can also be used. Now, coming to the sampling techniques which we usually use, sputum cytology is something which we have been reading about, but the sensitivity and specificity is significantly low. The bronchoscopy of biopsy in adjunct with EBUS TBNA plus minus EUSB FNA, given on the scenario how the lymph nodes are involved. Image-guided transthoracic core needle biopsy and fine needle aspirations. With pleural involvement, thoracocentesis. In cases where the EBUS or EUSB FNA is non-yielding, mediastinoscopy or VATS associated or open associated surgical biopsy, and the Chamberlain procedure, left anterior mediastinotomy. So these are the diagnostic procedures we have. Combined procedures which we can usually do for mediastinal staging is using EBUS TBNA in junction with EUSB FNA. That is the same endobronchial EBUS scope can be used first in the trachea and thereafter into the esophagus to have a complete mediastinal sampling. And this is something which we are doing and moving away from mediastinoscopy with similar results. Now, coming to the staging of lung cancer, now the latest TNM staging has come, where there has been no significant change from the 8th stage regarding the T stations, but the changes have come into the N and the M station. That is, in the N2 has been divided further into an N2A and N2B, where N2A refers to a single nodal N2 station, whereas an N2B refers to a multiple N2 stations involvement. And in cases of in the M stages, the M1C1 and M1C2 has been elaborated, where two indicates multithoracic metastasis in multiple organs. So a comprehensive workup would require a histological diagnosis, a tumor spread, that is the staging, and then analysis of the patient's performance score. Usually we use the ECOG PS score for assessment of that. And coming to the specialist involvement, which we would be having, a thoracic radiologist, interventional radiologist, thoracic surgeons, and pulmonologists working in conjunction for making a decision making regarding what will be the best methodology for approaching towards achieving the diagnosis of our patient. So the steps usually will be either we go from the most non-invasive towards the invasive, when most non-invasive with higher diagnostic yields are preferred. In case the non-invasive methods are not available to us in our armamentarium, we go towards the use of bronchoscopy for central masses. In cases where the primary mass cannot be assessed, or we want a mediastinal lymph node staging for assessment of the stage, we can use EUSB, EUS, and mediastinoscopy for assessment of nodal diseases with the help of rapid on-site evaluation to increase our yield and improving our techniques. In cases there are evidence of pleural effusion, a thoracosynthesis and cytology is the first step. If it is inconclusive without the absence, we move towards doing a thoracoscopic evaluation for specifically if it's a lymphocytic exudate with negative cytology. Molecular epidemiology and testing in the current era of precision oncology, in addition to conventional demographic molecular epidemiology, is becoming more and more important, because now after assessing, we have options to go towards targetable mutations, where we can give patients oral medications which can be taken similarly in the form like just an antihypertensive or an oral hypoglycemic agents. The side effect profile can be significantly brought down. Their need to come to hospital every third week for the chemotherapies can be come down. And these, if presence of targeted mutations, it has been seen that the PFS, that is the progression-free survival, is better than those patients if they are initiated on IV chemotherapy doublet regimens which we have been initiated. Coming over to EBUS-TBNA, which is the current standard of lung cancer staging recommended by ACCP guidelines over mediastinoscopy. The sensitivity of EBUS-TBNA is around in the range of 90 to 92% for detecting malignancy. However, the molecular genetic and PD-L1 testing increase the demand of the amount of tissue which we can have. Just if we are doing an EBUS-TBNA sample, something to be noted is that the EBUS-TBNA sample still not is validated for doing a PD-L1 testing. So in those scenarios, we would preferably try to go towards getting a bigger sample in the form of an EBUS cryo-TBNA, or if we can go using a mediastinal forceps biopsy needle. So these are the lymph node stations as well as the IISCL, the ones which we can access through EBUS-TBNA. The station 8 is and 9 is something which we can access through USB. So the N1 stage would be the ipsilateral hilar nodes. The N2A, that is a single mediastinal, more specifically subcarinal node. The N2 will be multi-stationed, where we are having a subcarinal along with that of the paratracheal lymph nodes. And N3 will be anything which is contralateral. It could be the contralateral hilar, contralateral paratracheal nodes, upper and lower, as well as the supraclavicular nodes. So does the needle size matter when we are doing the EBUS-TBNA? The needle sizes come across in various shapes and sizes, from ranging from 25 to 19 gauges. And the ACCP has given us a guideline that we preferably go for a 21 or 22 gauge for EBUS-TBNA. Now, with the advent of requiring more and more tissues, the flexible 19 gauge needle has also come into the foray. And the 19 gauge needle suggested to increase the diagnostic yield tissue size, which may improve the histological evaluation. But it was seen that the higher degree of tissue trauma, and there is more amount of blood aspirate, which is noted when we are using a 19 gauge needle. So to understand whether a 19 gauge needle gives us a better or an increased diagnostic yield in EBUS-TBNA, a study was done which showed that repeated aspirations with 20 gauge, they did in 2 arms, where they used the 22 gauge needles and compared that with that of the 19 gauge. And adequacy of PD-L1 testing was only established when there were presence of more than 100 tumor cells inconsistent with, and adequacy of molecular genome testing was labeled when there was more than 10% of the sample was tumorous. So it was found that the 19 gauge TBNA needle, utilizing the standard sampling method with that in combination with 22 gauge needle, it was done in a population of 48 patients. And although the diagnostic yield between these two were equivalent, and the concordance rate was only 83%, there were additional 4 cases where the 19 gauge needles could get the additional histological data. And conversely, in 3% of 3 cases, that is 6%, the diagnostic yield was only given by 22 gauge. Thus, the sampling with both 22 gauge and 19 gauge needle resulted in increased diagnostic yield from 92 to 99%. And the number of patients needed to sample were 13 patients to provide 1 additional diagnostic. And there were no additional significant complications which could be noted in the study. EBUS IFB technique, where We first make a rent through using our standard 22 gauge needle, and then we pass the mini forceps across the mediastinal node to get the biopsies. Now, the adjunct what we need in such a case would be that the EVAS IFB technique would be requiring a fluoroscope while we are doing a EVAS IFB procedure. So this is how the mini forceps looks under vision. We create a rent and pass our forceps. Then we open it and take a biopsy. This is the same thing. Now coming towards endobronchial ultrasound guided transbronchial cryonodal biopsy, which is the latest tool in our armamentarium, using the principles of cryotherapy, now going towards the mediastinum. It is a feasible technique, and complications of EVAS with that of the mediastinal lymphadenopathy. And here also similarly, first we make a rent through the tracheal wall via using the EVAS lymph node needle, and thereafter we can use a 1.1 cryoprobe into freezing a tissue and yanking it out, bringing a significantly bigger sample. There are two methods of creating this rent. One which is was first found out in which was fun for, is to use the EBUS needle, and the second technique is where we can use a electrocautery to create a rent under vision, and from there we can introduce the cryoprobe. And one of these techniques, that is using the electrocautery, has been proposed by an Indian, so that is a moment of proud for us interventional pulmonologists. So just a small video to show that we have created a rent and we have introduced our EBUS TBNA, cryoprobe, 1.1 cryoprobe into under vision. And after freezing it, we have taken it out. Again, for taking the second pass, we have first localized the sample. That is, the EBUS lymph node has been, and thereafter the cryoprobe has been introduced. Now coming towards EUSB, that is using something which was primarily being done. EUS was something which was initially done to access the station 4 and station 7 before the advent of EBUS in pulmonology. It was our gastroenterology colleagues who would help us in doing the mediastinal staging. So the same principle has been used by pulmonologists. That is, the EBUS scope is being introduced into the esophagus to access lymph nodes which are per se not accessible through the trachea. That is station 8, station 9. If there are liver lesions, that can be accessed, as well as the left adrenal gland, if requires a sampling, can also be accessed. Now, no talk on suspected lung cancer can be without the approach to us solitary pulmonary nodules, because more and more institutes are now trying to initiate a lung cancer screening program where we are trying to pick up patients who are still have not presented to us with symptoms, but we want to catch the disease early, because as we know from the global data that almost 70% of our patients, that is 40% in stage 4 and 30% in stage more than 3A, where the chances of going for upfront cancer surgery decreases significantly for our patients. For assessing the risk of malignancy, we have to use the Brock model, clinical prediction model, and Mayo Clinic model can be used from the clinical judgment and imaging characteristics. The pulmonary nodules can be divided into solid and subsolid, where it could be a part solid or a part ground glass nodule. I think my time's up, so I will quickly brush.
Try to wind up quickly.
Yeah, sure, sir. So I will just brush through what we are doing for our patients, and just some things regarding the imaging techniques, comparing CT with PET CT. Where CT, the nodule size will give us an idea regarding the solid component. Nodule attenuation will give us an idea regarding solid and subsolid versus GGOs. And the growth size, we will get an idea whether there is increase in the size or not. Calcification and fat considerations could be much more well delineated on a CT. Whereas the PET will give us an understanding of the biology of the tissue activity with the help of SUV. But the chances, the problem is that in a country like ours, there is a lot of false positive PET because of old infections, and tuberculosis is very prevalent in our country. And there are certain conditions like, say, invasive mucinous adenocarcinoma or carcinoid, which will not show adequate on a FDG PET, which we standardly do. And there has to be certain modifications which have to be made. These are the latest navigation systems like the Archimedes, the BTPNA, where bronchoscopically transparent parenchymal nodule access can be made by tunneling through the trachea and going across the parenchyma and taking a biopsy. Cone beam CT is now something, a new tool which helps us to improve our tissue access to the tissue to understand that that tool is in lesion, specifically when we are using the peripheral nodules we are trying to access. CT to body divergence is something like the most navigations beyond a certain generation, there is going to be a CT to body divergence. That is, say the the navigation pathway is showing us this is the location, but exactly the location is here. And in such scenarios, even a small, say a few millimeters is significant because you are going to miss your lesion if they are, say, in the range of a centimeter lesion. So without, these are the robotic assisted bronchoscopy systems, that is the Monarch and Ion systems, which are being used to bypass this city body divergence. And what we are doing in our in our hospital is doing a bronchoscopy if in the peripheral lesions, the ultrathin bronchoscope using radial EBUS, fluoroscopies. And as of now, we do not have navigation, so we are dependent on the bronchial branching tracing technique by Professor Kurimathu. Thank you.
Thank you. It's a good talk. Unfortunately, has to cut down because of time. My co-chairs, if they want to do ask any question.
So are there any questions from the floor to Dr. Chatterjee? Yes, please take the mic.
I am Dr. Vishwanath, medical oncologist from Chennai. I just want, that was very interesting about your nodal cryobiopsy which you are taking. Has it been useful in assessing the PDL1 and mutational status? That has not been, I think it is.
No, sir. EBUS TBNA has not yet been done. Regarding EBUS lymph node cryobiopsy, the studies are still undergoing because we just recently had got a data published where comparison head-to-head multicentric data in Europe has come out 2 days back only, where head-to-head EBUS versus EBUS cryobiopsy has been compared, and EBUS cryobiopsy has been shown to be a better technique. Regarding PDL1, yet the data is about to come, sir.
Dr. Chatterjee, one question.
Yes, ma'am.
In the cryobiopsy method,
Yes, ma'am.
is there any tissue damage?
Tissue damage?
I mean, when you're doing the histopath or the microscope pathologic examination?
No, ma'am, because the tissue damage is not happening. Unlike what we do with the forceps, where there could be a crush artifact that we can bypass via the cryobiopsy.
Okay. Thank you. If there are no other questions?
Any other question?
Other questions?
Before we move on to the next session, can we have a group photo?